I'm Dr. Ajit Sood. Good evening and welcome you all to this Best of Asian Organization for Crohn's and Colitis 2023. This year, 11th annual meeting of the AOCC was held in conjunction with the 6th annual Congress of Korea at Busan, Korea from 13th to 15th April 2023. AOCC offered a very high standard of update sessions of multiple topics of IBD. To bring these here, all the presented abstracts there were read and broadly divided into various major categories, and the most impactful ones will be discussed here in a short time. I'm underlining in a short time. I'm grateful to AOCC for having agreed to this virtual event, and we are joined here by senior eminent faculty, Professor Hu Zhang from China and Professor Takenori Kanai from Japan. I'm not very sure about Dr. Kanai from Japan. In addition, we have senior national faculty, Professor Rakesh Kochar, Dr. Naresh Bhatt, Professor Govind Makharia, and Dr. Philip Matthew. I welcome you all again and invite Dr. Matthew Philip and Professor Govind to introduce the faculty for the first session and take the proceedings further. Matthew and Govind, please.
Govind, thank you so very much, Dr. Ajit Sood, sir. I think this is a wonderful to join together to discuss some of the important abstracts which are presented during AOCC 2023. And on behalf of Matthew Philip and all the panelists, I welcome you to this session on Best of AOCC. We all know that AOCC had a wonderful abstracts presentation, and many were oral and posters. And what we thought that select some of the best ones which are close to clinical practice and also close to science to be discussed today. We have two sessions, as Dr. Sood said. In the first session, may I invite Dr. Arshdeep Singh to present abstracts related to biologics and small molecules, and also about ultrasound, which are becoming very, very important, especially intestinal ultrasound for its validity or use in patients with IBD. Dr. Arshdeep Singh is an assistant professor at Dayana Medical College in Ludhiana. Ludhiana is another part of India, and he's a colleague of Dr. Ajit Sood. Dr. Arshdeep Singh, please. And after his presentation, we'll discuss questions. I may also request all the participants who join online to put their questions in the chat box so that we can address all of your questions during discussion session. Dr. Arshdeep?
Then mention about the panelists also who are available.
So, right. Other thing was that we have three panelists here for this session. They are Dr. Ajit Sood. All of us know Dr. Ajit Sood is a professor and head of department of gastroenterology at the Dayanand Medical College in Ludhiana, India. We have Dr. Usha Datta. He's again head of gastroenterology at PGI Chandigarh, and Dr. Hu Zhang from China. So we also request all three panelists, and we'll invite them once we come back to discussion session. Welcome, everyone.
Harsh.
A very good evening to one and all. Welcome to this first session of Best of AOCC 2023. In this first session, we'll be discussing three segments. First, biologics and small molecules in IBD. Secondly, we'll move on to colitis-associated cancer. And the third will be intestinal ultrasound in IBD. So moving on to biologics and small molecules. The first study is...
Can you make it slide presentation? Slideshow?
The first study is the efficacy and safety of Ustekinumab in Asian patients with moderate to severe active Crohn's disease. This is a subpopulation analysis of Asian patients in the UNITY and the IM UNITY long-term extension studies with a 5-year follow-up. So Asian patients from these studies were subgrouped and analyzed. There were a total of 63 patients who entered the long-term extension studies at week 44 and were followed through week 252, that is 5 years. 8 patients who received placebo were discontinued after unblinding at week 44. So 55 patients were analyzed at the end. The outcomes that were assessed were long-term efficacy in the form of clinical remission and clinical response, and long-term safety defined as the adverse events per 100 patient years. So if we look at the efficacy at week 44, there were two groups of patients, one who received Ustekinumab every 12 weeks and the other group who received every 8 weeks. So in the combined Ustekinumab population, 60% of the patients had clinical remission, whereas 81% patients had clinical response. If we followed these patients till week 252, 33% of the patients maintained their clinical remission and 45% of the patients
Your
maintained
slides are
their
not moving.
Harshad,
clinical
Harshad,
response.
We are
Harshad,
not
can
seeing
you
your
just,
slides.
Harshdeep, make it
They're
into
not moving.
slideshow.
Slides are not moving.
Is
Make
it
it
okay
into
now, sir?
slideshow. Make into slideshow, please.
My screen sharing has been paused by the technical support. If somebody can.
Sir, please share your slides again.
Now it's fine.
Yes, sir. Please continue.
I'm not able to move my slides now.
Just click on the slides once.
Just do it.
Yes.
Okay. So I have summarized this that at week 252, 33% of the patients maintained their clinical remission and 45% of the patients maintained their clinical response. If we look at the safety, the adverse events that were reported in the terms of per 100 patient years, the total of 267 adverse events were reported in the Ustekinumab group, out of which 23 were serious, 98 were infections, and 4 were serious infections. When we compare these with the patients who received placebo, there was not a significant difference between the two groups. 8 patients who discontinued Ustekinumab due to adverse events ultimately had worsening of Crohn's disease, and no deaths or malignancies were reported during the follow-up of 5 years. The second study is again a long-term extension study from the Unify study that evaluated Ustekinumab in patients with ulcerative colitis. Again, Asian patients were subgrouped and analyzed separately, and a total of 53 patients were included in the analysis. The outcomes that were reported were symptomatic remission, that is Mayo stool frequency subscore of 0 or 1, and rectal bleeding subscore of 0. If you look at the efficacy of the Ustekinumab in patients with ulcerative colitis, again, a proportion of patients received a 12-weekly regimen and a proportion of patients received 8-weekly regimen. So if we look at the overall efficacy at week 44, 58% of the patients were in symptomatic remission, and at week 200, that is 4 years, 49% of the patients had clinical remission, meaning that approximately 8 to 9% patients, they lost response over a period of 4 years. Interestingly, if we look at the subgroups according to the previous biologic experience, the biologic naive patients performed better, as 78% of the patients sustained their symptomatic remission over a period of 4 years, whereas the patients who had failed biologics previously, only 34 patients could sustain symptomatic remission at the end of 4 years. If you look at the safety, the combined Ustekinumab group versus placebo, there were no significant differences in the adverse effects, serious infections, or deaths and major cardiovascular adverse events. So to conclude, long-term efficacy and safety of Ustekinumab in Asian subpopulation with moderate to severe active UC and Crohn's were consistent with the overall study population that was reported previously. Clinical remission and clinical response were maintained without any new safety findings in Asian patients through 4 years follow-up for UC and 5 years follow-up for Crohn's. Clinical remission rates in biologic naive patients with UC were greater than biologic experienced patients. The next abstract discussed Ustekinumab in perianal fistulizing Crohn's disease, and the results were reported in terms of radiological fistula healing. The different outcomes that were used to report the efficacy of Ustekinumab in perianal fistula were Crohn's disease activity index, SCSCD, that is the endoscopic disease activity index, perianal Crohn's disease activity index, Crohn's anal fistula quality of life, and von Asch score, which is a radiological score. Now, for the benefit of the residents and fellows who are attending this event, the MRI-based von Asch index takes into consideration different parameters like number of fistula tracts, location of the fistula, extension of the fistula, hyperintensity on T2 whited images, the number of collections, and rectal wall involvement. So in this study, 108 patients were included, out of which 44% patients had complex perianal fistula. And if we look at the radiological response, radiological healing was seen in approximately 45% patients, with a partial response noted in 31% of the patients with Ustekinumab. Now, the authors also analyzed the Ustekinumab trough levels and divided the serum trough levels into 4 quartiles, and they found that the trough concentration of 2.11 microgram per ml predicted fistula clinical remission with a sensitivity of 93%, as the area under curve shown in this graph is 0.8. Another study from Japan evaluated the long-term outcomes and prognostic factors for Vedolizumab-treated patients in patients with ulcerative colitis. So 172 patients treated with Vedolizumab between November 2018 to October 2022 were retrospectively analyzed, and clinical remission was defined as partial Mayo score of less than equal to 2. 77 patients, that is 45% of the patients, had previously experienced biologics or JAK inhibitors before starting Vedolizumab. The cumulative rates of treatment persistence at 3 years was 50%. If we look at the clinical efficacy, the clinical remission at 6 weeks with Vedolizumab was 51%, and at 14 weeks it was 58%. Now, the authors also looked at the predictors of long-term response to Vedolizumab, and they found that clinical remission at 6 weeks was strongly associated with clinical remission at 1 year, 2 years, and 3 years. Also, if there was a concomitant use of immunomodulators at the time of induction therapy with Vedolizumab, it predicted clinical remission at 1 year. The adverse events were mild, like nausea, fatigue, headache, drug eruption, pneumonia. 1 patient had cerebral infarction, and 1 patient discontinued Vedolizumab due to severe nausea and fatigue. So the long-term outcome of Vedolizumab-treated Japanese patients with UC was comparable to Western data, and achievement of remission at 6 weeks after starting Vedolizumab contributed to a long-term clinical remission. This study evaluated the post-marketing surveillance of tofacitinib safety in patients with ulcerative colitis in Japan. A total of 1,660 patients were included in this interim safety analysis, with a total of 2,200 patient years of exposure. And if we look at the adverse events, 24% of the patients had adverse effects, 2% of the patients had severe adverse effects, and herpes zoster, which is the commonly reported infection, was also commonly seen in patients with UC from Japan, seen in 79 patients, but most of the patients were non-serious, and only 4 infections with herpes were serious. No deaths occurred during this period. So the overall safety profile of tofacitinib in patients with UC in Japan was comparable to tofacitinib safety data that has been reported previously. However, herpes was higher in this interim analysis as compared to the rates reported in the tofacitinib UC clinical program. The next abstract that was presented was the VIEWS trial, that is withdrawal versus continuation of thiopurines in Vedolizumab-treated patients with ulcerative colitis. This was a multicenter RCT from Australia, and patients with ulcerative colitis who were on Vedolizumab maintenance every 8 weekly and on a thiopurine for more than 6 months. Plus, all these patients were in steroid-free clinical remission and endoscopic remission were included. Now, these patients who were on a combination of Vedolizumab and thiopurine in clinical remission as well as endoscopic remission were randomized in a ratio of 2:1 to either continue or withdraw thioprines. The primary outcome was the vedolizumab trough levels at week 48, and the secondary outcomes included rates of disease relapse, endoscopic remission, histologic remission, combined histological and endoscopic remission, fecal calprotectin, and adverse events. The two groups were similar at the baseline with no major differences. And if you look at the primary outcome, there was no difference in the week 48 vedolizumab levels between the two groups. However, if we look at the secondary outcomes, the withdrawal group had higher relapse rate, and this trend of higher relapse rate was more for bio-exposed patients. In the continue group, there were significantly higher histological remission, higher rates of combined histological and endoscopic remission, and lower fecal calprotectin values. So this is to summarize, the patients who continued thioprines along with vedolizumab had higher relapse-free survival. On multivariate analysis, the histological activity at baseline was found to be a predictor of disease relapse, but despite this histological activity, the patients who continued thioprines along with vedolizumab still had higher relapse-free survival as compared to the patients in which thioprines were withdrawn. So although thioprine withdrawal did not affect vedolizumab levels, it increased fecal calprotectin, histologic and histologic endoscopic activity in patients with UC. In those with histological activity, thioprine withdrawal significantly increased the risk of disease relapse. The next study is a nationwide population-based study from Korea. This used the Korean National Health Insurance Claims Database and included a cohort of IBD patients who were already on thioprine treatment before starting the anti-TNF therapy. This abstract compared the outcomes of patients who stopped thioprines after anti-TNF initiation with those who continued. And the primary outcome was a composite of IBD-related hospitalizations, new corticosteroid use, and intestinal surgeries. So a total of 6,235 patients, 1,900 had UC, 4,000 plus had Crohn's. Out of these, 430 patients with UC stopped thioprines after initiation of anti-TNF, and 900 Crohn's patients stopped thioprines after initiation of anti-TNF. So if we look at the results, in the patients with UC, the continuation of thioprines resulted in a better response in terms of low rates of intestinal surgery, low rates of IBD hospitalization, low rates of corticosteroid use as compared to those patients who withdrew thioprines. In patients with Crohn's disease, there was no effect on continuation or withdrawal of thioprines on intestinal surgery, hospitalization, or corticosteroid use, though a trend towards lower composite outcomes was seen in patients who continued thioprines. So on multivariate analysis, patients with UC, the composite outcomes of intestinal surgery, hospitalization, and new corticosteroid use was higher in patients who discontinued thioprines. The second segment is the colitis-associated cancer. So this study from Taiwan included 65 patients retrospectively who were found to have colitis-associated cancer. The UC to Crohn's disease ratio was 12:1. Most of the patients with UC had pancolitis, active endoscopic activity, that is Mayo endoscopic score of more than or equal to 2. The lesions appeared non-polypoidal and ill-defined in a majority of patients. However, white light endoscopy was able to detect most of these lesions. The common site of the colitis-associated cancer was left-sided colon. Colectomy was seen in around 60% of the patients, whereas concomitant PSC was seen in only 1% of the patients. Another important point is that elevated CA levels were seen in only 42% of the patients. Another study from Japan, which retrospectively analyzed the patients with colitis-associated cancer, the UC to CD ratio was 2:1. Majority of the patients with UC had their CRC diagnosed on surveillance endoscopy, whereas nearly 50% of the patients with Crohn's had symptoms before their CRC was diagnosed. Another study which compared the clinical features and prognostic factors of CRC in patients from USA and from Korea A total of 236 patients with 200 from Mayo Clinic, Florida, and Asan Medical Center in Korea that were analyzed for colorectal cancer in patients with Crohn's disease. This is specific for Crohn's disease. And when we compare the cohort from these two different centers, we can see that the median age at CRC diagnosis was lower in Asian patients, lower BMI, lower median time from initial Crohn's to CRC diagnosis. PSC was not seen in Asian patients, whereas nearly 11% of the patients had concomitant PSC from the USA cohort. The CD location at the time of diagnosis was L3, that is ileocolonic in Asian patients. The behavior was most of the patients had inflammatory disease, with 50% of the patients having perianal fistula in the Korean cohort. But when we compare the CD location at the time of CRC diagnosis, the location remained confined to ileocolonic in Asian patients, but behavior that was predominantly inflammatory at the time of diagnosis changed to either stricturing or penetrating phenotype at the time of CRC diagnosis. Again, perianal fistula was more common in Asian patients at the time of CRC diagnosis. Immunomodulator use was more common in Korea. Median biological therapy exposure time was again less in Korea. Most of the patients in US were diagnosed on surveillance colonoscopies, whereas Asian patients were symptomatic at the time of diagnosis of CRC. The most common location of CRC in Asian patients was rectum, whereas that is 86%, whereas only 42% patients had CRC in rectum in the American cohort. The curative surgery could be done in 43% of patients in USA, which was significantly higher as compared to the Korean cohort. If we look at the histology, majority of the patients in US had adenocarcinoma, whereas majority of the patients in Asia had mucinous features, that is mucinous adenocarcinoma on histology. On multivariate analysis, CD remission at the time of diagnosis of CRC, diagnosis after 2001, and CRC diagnosis by surveillance were protective factors from death, whereas age, unresectable CRC, higher CRC stage, and signet ring cells in histopathology were associated with higher risk of death in this group of patients. So some clinical characteristics were different between USA and Korean patients. The risk of death was not significantly different. CD remission, surveillance colonoscopies, and newer CRC treatment strategies appear to reduce the risk of death. The last segment of this first session is intestinal ultrasound in IBD. The first study evaluated the role of intestinal ultrasound in patients with Crohn's disease and correlated with serum and fecal biomarkers. So on intestinal ultrasound, they evaluated bowel wall thickness, loss of bowel wall stratification, increased Doppler activity, and mesenteric fat trending. 127 patients were included. 74 patients showed active bowel inflammation, with the most common site of inflammation being terminal ileum. And they concluded that disease activity determined by intestinal ultrasound showed significant correlation with biomarkers. And this concordance was better with active small bowel disease than those compared with other disease locations, that is colonic or ileocolonic, if we take fecal calprotectin cutoff of 150 milligrams per gram. Another study evaluated the sonographic outcomes in patients who received Ustekinumab, and 30 bio-experienced patients who were inducted with Ustekinumab were included. And after 6 to 9 months of induction, 16 patients, that is 53% patients, had sonographic response. The shear wave elastography in responders was 10 versus 13 in the patients who did not respond. So sonographic measurements can be a helpful parameter for evaluating response to Ustekinumab in bio-experienced patients with Crohn's disease. The last abstract for the first session, which evaluated the role of intestinal ultrasound in patients with acute severe ulcerative colitis. This was a multi-center observational cohort study from November 2019 to July 2022. The intestinal ultrasound was performed at 4 time points. Number 1 at the day of hospital admission, day 3 at the time of discharge and during the follow-up in outpatient department. So 32 patients, out of which 16 responded to corticosteroids. The bowel wall thickness decreased in all the patients who responded to corticosteroids. The ROC curve showed that an absolute reduction of bowel wall thickness by less than 1.4 millimeters and relative bowel wall thickness reduction of less than 20% predicted non-response and need for rescue therapy. On the contrary, a reduction in bowel wall thickness and absence of Doppler activity on day 3 ultrasound enhanced the predictive capability of intestinal ultrasound. So the accuracy of intestinal ultrasound in acute severe ulcerative colitis was demonstrated. It may allow the clinicians to expedite initiation of rescue therapy for patients who require salvage therapy. Thank you and happy Independence Day in advance.
Thank you, Ashley, for this wonderful selection of abstracts, and it was very useful. And at present, we have noticed that we have got only 20 minutes left now for discussion. And he has discussed certain areas. One is the newer biologics and anti-integrins, etc., for therapy for IBD. And second aspect is the combination. And third is CRC or cancer in IBD. And fourth, intestinal ultrasound. So let us take the first question. Let us start with Ajit. So we have got Ajit. I will ask him question. You give a comment, and I request Dr. Sang as well as Dr. Usha Dutt to comment on that. See, now we have got newer drugs like Ustekinumab and Vedolizumab available in India and in many parts of Asia. How do you, in your practice, how do you position this? Where will you take up? Will you start with these drugs as a primary therapy in a naive patient, or you will start only after biological exposed patients? How do you select your biologics, these type of biologics in your practice? Dr. Ajit Sood, you have got 2 minutes.
Thank you. Just quick comments that I'd say that regarding ulcerative colitis, good 70-80% of the patients, they respond very well to 5-ASA steroids or immunomodulators. And it's only the difficult patients where we consider the option of biologics and or small molecules. In India, specifically in developing countries, the parameters what decide the selection of the drug is efficacy, safety, and the cost. Now, small molecules, we know the cost is quite minimal in our country because of availability of generic preparations. UST is emerging as a very good drug. For that matter, I will say all anti-23 blockers are the drug of, they seem to be the drug of future. But when we say that which drug is to be preferred, the cost-wise, JAKis get preferred. The efficacy and safety-wise, I will say anti-23 are preferred. Regarding Crohn's disease, there's no question because tofacitinib, the drug which is available so far, is not effective in Crohn's. So for UC, I'll say both, depending upon the financial status of the patient, both can be used. Both are both can be effective.
In your practice, a patient coming with ulcerative colitis, patient is failed in primary therapy like 5-ASA, a combination of immunosuppressants, and patient had multiple steroid courses. What will be your next choice? Will you go for anti-TNF or will you go for vedolizumab in a case of ulcerative colitis?
See, at this moment, we are going more for JAKis.
You go for tofacitinib.
Yeah, we are going for JAKis, and the choice between biologics, between anti-TNF, infliximab versus UST versus Vedo. Vedo is actually a bit slow. So if it is a patient has very severe disease, then we have to choose between infliximab or Ustekinumab. Vedo has a special role, like in people who are elderly, or who have a past history of malignancy. I mean, they are the two group of patients where Vedo is to be preferred. But extraintestinal manifestations, Vedo's role is less.
So, Professor Sang, what is the practice in China and any other parts of Asia, other centers of Asia, or at least in China? Please tell us, how do you place these new molecules like vedolizumab, ustekinumab, and tofacitinib in your practice in IBD? Very big comment. Did you follow my question?
Yeah. I think in my experience, I think the both UST and Vedolizumab are very nice medications, and for the TOFA, and it's just approved for IBD patients, so it's quite used, not very common now. I think TOFA is a very effective medications based on the limited number of the patients. As for my experience, I think UST is very appropriate for the moderate to severe Crohn's disease. And so in China, UST is not approved for ulcerative colitis. So UST is used widely for Crohn's disease, and for Vedolizumab is approved for both ulcerative colitis and Crohn's disease. But in my experience, and it's much more appropriate for colitis, ulcerative colitis, rather than the Crohn's disease, because Vedolizumab demonstrate its efficacy more slowly. It needs us more patience.
Okay. So in your opinion, Vedolizumab, you use it for ulcerative colitis, and Ustekinumab for Crohn's disease. TOFA is only just recently available in your country. So Usha, Doctor, Usha is there? Hi,
Yeah.
Usha.
Hi.
Very quick comment. How do you place your biologics? How do you?
Yeah. So right now, we do use Infliximab, and now Video has started coming into the market. TOFA is the commonest biological small molecule that we are using right now in our setup. So I would think that from Infliximab, we have moved to Video and now to TOFA.
Okay, I think that's okay for the first part. Dr. Govind Makhiyara, can you take the second aspect, because we have answered most of the TOFA slip, except the safety issues. But I think we can go for the third question if you don't mind.
Just for clarity purpose for the audience, Dr. Sood, let me just summarize what you said, and all three of you said, that in those patients with ulcerative colitis, if they have acute severe ulcerative colitis and they fail to IV steroids, then you can use either Infliximab or cyclosporine or TOFA. Am I right, sir? So you can do any three of them.
Yeah, actually, we didn't discuss so much of acute severe ulcerative colitis. The discussion was more focused on moderately severe ulcerative colitis. I think acute severe ulcerative colitis is a bit separate group. There, of course, Infliximab versus cyclo or cyclosporine versus in combination with Vido, these are the options. I mean, whether we can use UST for acute severe ulcerative colitis is again being considered, but not proven at the moment.
Okay. The second part was, so in those patients who have a steroid refractory ulcerative colitis or steroid dependent ulcerative colitis, so the algorithm till now had been to use azathioprine. If no response, you add Infliximab. Do you suggest that you can replace Infliximab by tofacitinib or Ustekinumab?
TOFA, yeah. If we have to use AZA and the patient has moderately severe disease, then we know that if we are starting AZA, then we have to give another course of steroids along with that. So otherwise, AZA will not act. So the choice is between TOFA and Infliximab and or UST. I think if Dr. Govind, cost doesn't matter. We have the options of both the drugs available. With safety concerned, UST gets preferred over TOFA.
So my point of making this conversation was to let everybody know that now we have a lot of options. Earlier we had just one option. Now we have a lot of options depending upon the affordability of an individual. There are choices available. One important question comes in regards to tofacitinib, and a lot is talked about, which Ars also talked about, the side effect profile. And one important side effect of tofacitinib is vasoconstrictor reactivation. So, I mean, we have so many biologics. Why do we specifically talk about varicella in those patients where we consider to use tofacitinib? Any specific reason, Dr. Sood?
Yeah, I mean, for viral infections, it's the interferon gamma which fights the infection, which controls the virus infection, and JAK inhibitors they interfere with the interferon gamma. So this is one postulation that why herpes gets reactivated in patients who are on JAKs, and it's a class effect. With the new one, filgotinib and UPA also, we are likely to see the same virus, though of less magnitude as compared to tofa.
Dr. Sood, I have a question for you that now with Shingrix available, all patients on TOFA, should they be given Shingrix, and which subset, if not all?
Ideally, yes, all patients, we should vaccinate at least a month before starting TOFA. And if not, then at least elderly people or people, I mean, who are diabetics or who have high risk of herpes. Elderly people who have been exposed to previously to biologics, they are the group of patients who are more prone to get herpes. Asians as such are more prone compared to Westerners.
Dr. Rosal, can we go to the third question now?
Yeah. One more the question which come from Dr. Say Sumit Bhatia, and he had asked this question to Dr. Sood that do you use Ustekinumab in ulcerative colitis, considering it is not yet approved in India?
We have very limited experience. We have used UST in 2 patients, both with Crohn's with the perianal fistula. But we have results of a Unity trial, which has convincingly shown the efficacy of UST. And Arsh has also presented a very nice study showing the long-term efficacy of UST in patients with in UC. I mean, of course, the issue remains whether it is approved or not, but of course, there is a concern. But its efficacy has been proven.
There are more questions coming up. What is the role of tofacitinib in young unmarried females by Arshdeep?
Sorry?
There is a question on role of tofacitinib in unmarried females.
Unmarried females. No, I mean, it's not to be unmarried females, there's no restriction. It's only that person can't conceive while being on TOFA. Person has to be off TOFA for at least 4 weeks before conception is planned. Unmarried females, it shouldn't matter.
Many questions are coming up. I think we'll take one issue one by one. Dr. Govind, can we go?
So I think the one important issue with any drugs which is launched is especially biologics and all those or small molecules. The question comes about side effects. I think one has to consider the side effect profile of a given drug before you prescribe, and one must be aware that what side effect, when they do occur, and what kind of preventive strategy you do. So this, I think, all of us who use biologic must remember the side effect profile, and which are so very important. Now, moving to another issue about colorectal cancer in ulcerative colitis. I think we have enough data, and also presented today by Arshdeep, 2 or 3 studies. All of them point out that the risk of cancer, risk of colorectal cancer in patients with ulcerative colitis and also Crohn's disease is higher than compared to general population. There was a belief sometime back, say about 2 decades back or about 10 years back, people believed that in Indian patients and also Asian patients with IBD do not develop cancer. And there are multiple studies have appeared. One study from Delhi, from Dr. Vinita Ahuja's group, and also from many Asian countries this point of time. So my question was to the panelists that since this is now relevant, that all those patients with ulcerative colitis and also some with Crohn's disease, as the disease goes on, do you practice a strategy of surveillance at your center? And if you do, how do you do it? Do you do by doing a multiple biopsy from every segment, or you guide yourself taking biopsy by using chromoendoscopy? to look at the lesion and then take biopsy, targeted biopsy. What do you have a protocol? I'm going to ask Dr. Sood and Dr. Zhang and also Dr. Datta at three different, two from India, one from China.
Can we hear from Dr. Zhang first?
Okay.
Yeah, I think colitis, colitis-related colorectal cancer, I think it's an important issue for the IBD patients. Colitis-related colorectal cancer is really not very common in China now, but it is still has increased more than 30 times based on one national studies in China. But it is still, I remember the incidence is about, I think it's less than 1%. I think the most important reason is that many colitis patients have not very long term of the disease. Yeah, I think with it, with the time goes, or I think the patients have been affected for longer. I think the possibility or the risk of the colorectal cancer will increased in future. And for the how to detect it in our clinical practice, I think the endoscopy is most important. If we find some areas in the luminal or in the mucosa, will take biopsies. If the biopsy or if the pathological examination reveals some neoplasia, also I think we will set our program to follow it, to follow the patients or discuss with the surgeons.
Right,
Yeah.
right. Yeah. Dr. Govind, can I just?
Please go ahead.
Yeah, thank you. I just want a few quick comments. Right, we should always remember, as you rightly said, that it's an important issue which we should always keep it in mind. And this colitis associated cancer, all patients with UC, depending upon the duration of the disease and the extent of the disease, and patients with Crohn's who have at least 30% involvement of the colon, they should be considered for surveillance. Now, the issues are that how to do it, whether it's a trauma endoscopy or virtual trauma endoscopy. We have different image enhanced scans, whether to do target biopsy or whether to do random biopsies. These are so many issues which remain unanswered. But on top of it, we know that colitis-associated cancer behaves in a little different manner, that the lesions are more non-polypoidal and they're more confined to the left side, and they're likely to be multifocal rather than a single lesion. Now, when it comes to a surveillance program, I admit here that because of both at patient's level as well as at our level, we don't have a very robust surveillance program at a center. I mean, it's not something good to mention, but at the moment, this is one area where we need to improve, and hopefully we will improve on this area. But I would like to say that patient participation is also very poor. And most of the patients, once they're all right, they don't want any intervention. Another point, I have little difference of opinion with Dr. Zhang. Dr. Zhang said that the the colitis-associated cancer is on the rise. Now, with the better endoscopy techniques, we can pick up dysplasia early, and with better drugs which can control inflammation better. So with these two reasons and better awareness, the cancer risk is thankfully on the decline, not on the rise. What have this is what studies have shown, that over past 10 years or 15 years, the incidence of cancer in IBD is on the decline actually. But we should always remember that this is one complication which can surprise us anytime.
I think this is a wonderful point you made. Wonderful point you made that as you control inflammation, just a minute, please. Just a minute. It's a very important point you made, that as better control of inflammation, both in ulcerative colitis and Crohn's disease, the long-term risk of strictures, fistulae, hospitalization, surgery, and also long-term complication like cancer should decrease. There's a lot of data about decrease in the rate of surgery, hospitalization, and luminal complication. There are a good number of data now appearing that they are better. But again, we expect the studies to appear in time to come, that cancer rates pre-biologic and post-biologic would be better as predicted by most of the IBD experts. And Usha, you had a question. And
yeah, I just said that in India, definitely we have to step up active surveillance of our patients. Our patients do keep moving from one city to the other. So pan India, we should have a program by which we keep them under our net for surveillance. Second is, I noticed that CEA levels are not useful at all, according to this particular study which Arshdeep had presented. So colonoscopy with NBI, I think chromoendoscopy is also time taking and also needs more planning and all that. So why not use colonoscopy with NBI for screening instead of using chromoendoscopy? What are your views about it?
Yeah, if I could just add one line, this multi-DNA based FIT technique may help in early pickup of tumors in patients. In addition to this, can be supplement to colonoscopy.
I think in interest of time, we close segment 2. Now we have one more segment, it's ultrasound. But this is a good time that the CCFI take this question of surveillance, as we had many guidelines created by CCFI and ISC. And this is time to think about what is the best practices of looking at cancer in patients with IBD, both ulcerative colitis and Crohn's disease. And this will be a topic to discuss amongst experts and put useful, or the process of how do you do it, when to do it, and what are the various methods, as Dr. Usha said. Now, moving to the third part, I maybe invite Dr. Matthew Philip to lead on for a couple of minutes about intestinal ultrasound, which is very, very important modality for screening, for severity, and also follow a patient with Crohn's disease especially.
So let me start with Usha. See, first of all, I agree that we need to have some technique of having a proper screening for these patients. And I am for with Usha on narrowband imaging, using narrowband imaging in all the patients of Crohn's, ulcerative colitis. But that is not useful for Crohn's disease, but ulcerative colitis is very useful. But anyway, we'll move to the new issue, that is the role of intestinal ultrasound. We know that when we do ultrasound, in especially in Crohn's disease patient, and to a certain extent in ulcerative colitis, we see thickened bowel and we tell that this is it, and you look at the Doppler signals, and we know that there is evidence of inflammation and stricture, etc. And also on significance of dilatation, which actually tells us that the stricture is more fibrotic. Dr. Usha, how do you foresee this intestinal ultrasound as a future tool? And do you think this is going to replace our conventional cross-sectional imaging? Very quick comment from you, then followed by this. After that, we have to close.
I think intestinal ultrasound will emerge as a point of care assessment in the OPD setting, as well as in this study which Arshdeep showed in acute severe ulcerative colitis to assess response, because we cannot do colonoscopy in acute severe ulcerative colitis to assess response. So in these two situations, definitely it will be of role. And I think it will replace unnecessary CT scans and cross-sectional imaging. And especially for terminal ileal involvement, it is a very useful technique compared to colonic involvement.
Now, for the first diagnosis, we cannot replace cross-section imaging. That is what I think. The first diagnosis where you want for a Crohn's disease, you have to have a good cross-section imaging, like CT angiography or MR angiography. So, Professor Sang, what is your thought about the role of future of intestinal ultrasound?
I think the intestinal ultrasound is a marvelous tool for us to detect the patient's lesions, especially in the small intestine, and to assess the intestinal inflammation. I think I will choose for Crohn's disease more frequency. I think I very well choose it for colitis because we can assess the inflammation based on the endoscopy. And it's very easy and directly and more precise to assess it. The inflammation or the colonic lesions. And for the small intestine lesions, I think ultrasound can give us more values, especially for some patients. I think firstly it's non-invasive and it's cheaper. It's much more easier or is very easy to available to for patients, and is particularly for some patients, and they're very young or pregnant. The patients, I will choose it. And for CT and the MRI, I think it also is CT and MRI can give us much more figures or images for us, not the operators, to assess it or repeatedly. And the ultrasound has great disadvantages. That's to assess the intestinal lesions just for the operators, not for the clinical or the doctors or for other doctors. And for CT and MRI can give us more information and is more, I think, from other doctors can to assess it repeatedly. Okay.
Thank you. Thank you, Professor. Is it okay? No, continue.
Yeah, I can continue. And for the, I remember I've submitted one abstract to AOCC or ECHO. We found the intestinal ultrasound to assess the intestinal and small, in particular for the intestinal, for the small intestinal lesions, and the efficacy is equal to CT and MRI.
Thank you, Professor Sang. I think before the final word from Dr. Ajit, let me quickly ask Naresh Bhatt and Dhruva Banerjee, who are very fond of intestinal ultrasound. What is your practice? You recommend?
Yeah, I think intestinal ultrasound has been there in our unit for about 5 years, and we've been finding it extremely useful. I agree that terminal ileum is extremely easy to sort of image. Yes, except the rectum. The rest of the colon is reasonable, but then the role in ulcerative colitis is sort of, you have other modalities to rely on, but Crohn's, especially ileal, I think you can monitor them pretty well. Point of care, as he said,
Dr. Bhatt, you use it as a follow-up test. Am I right?
Yes, we routinely, like treat to target, we use it with the biomarkers.
Ruba, very quick comment. Ruba?
Yes, the quick comment is I completely agree with what Dr. Naresh.
Okay, Ajit Sood.
Yeah, it's actually two things. One is treat to target, where we should, if we combine it with the fecal cal and the CRP and intestinal ultrasound, the three together can make a very good combination to predict whether mucosal healing is occurring or not. And I'm sure sooner than later we are going to have a validated scoring system for remission based on IBS. So we are waiting for that. That will happen in near future. So the other situation is where we can assess the response in acute severe ulcerative colitis, where it cannot replace the other modalities like what we use the other scores, but this can be one of the other tests which can predict. And what Dr. Usha said is very right, that once we know that if the patient is in clinical remission, is in mucosal healing based on biomarkers and intestinal ultrasound, then if we still want confirmation, we can go for MRE rather than a time-based MRE or CT.
Okay, Dr. Govind Makar, can you just conclude on this session?
I think I'd like to thank
I can just,
Dr. Rupa. Yes, please. Yeah, please, Dr. Rupa.
just a quick one. I think this is a new skill for the gastroenterologist. And I think all of us should learn to do it. Can you hear me? So
Yes.
I think everybody, all of us should learn to do it. And we are holding the IBUS course in November. So that is just going to be the beginning. I don't know whether I'm audible or not,
Yes, you are not
but
very,
I think
there is, but many centers in India are doing it, though they are not publishing it all. Of course, there are some people have to take lead on disseminating the knowledge on that. So in our unit also, we do it. We have a specific machine for that with a soft part ultrasound. And so final conclusion by Dr. Govind Makaria. Thanks a lot, Govind.
So along with Dr. Matthew Philip, we'd like to thank.
But because his center has a lot of experience with intestinal ultrasound, so Dr. Naresh
In interest of time, can we close this session? Along with Dr. Matthew Philip, I'd like to thank all the three panelists, Dr. Ajit Sood, Dr. Jiang, and Dr. Usha for a fantastic response to questions. I think this has been quite a learning experience. I'd like to thank Arshdeep for choosing important abstracts which are very relevant to be used in practice. And he presented all the abstracts so very well. With that, hand over to Dr. Ajit Sood for session 2.